The gold standard for the diagnosis of invasive fungal infections is culturing clinical specimens such as tissue, sputum, urine, wound, or blood to isolate the etiologic fungal agent, provided that the samples are from sterile sites such as blood, tissue, or cerebrospinal fluid, in which fungal infection can be documented. Culture can be useful to determine the sensitivity of the isolated fungi to antifungal agents and identify resistant species, and are thus needed to optimize patient management. The sensitivity of culture differs among published studies. In cases with a specific fungal infection such as zygomycosis, the etiologic agent loses its viability during tissue homogenization before culture. In addition, this method can produce false negative results if the clinical specimens are obtained after treatment with antifungal agents. Collecting appropriate tissues and other sterile specimens for culture or histology from patients whose condition is unstable, especially when neutropenia is present or platelet count is low, is difficult because it requires invasive procedures. The sensitivity of blood culture for the diagnosis of fungal infection is controversial. Multiple or repeated blood cultures should be performed to increase the likelihood of detecting candidemia, and filamentous fungi are rarely isolated from blood. One of the most commonly used techniques to aid in the diagnosis of invasive fungal infections is the detection of fungal-specific antigen clinical samples. Recent advances in diagnostic techniques for invasive fungal infections include the antigenic detection of galactomannan for invasive aspergillosis, IA1,3-beta-D-glucan, a pan-fungal marker for aspergillosis, candidemia, and pneumocystis jirovecii pneumonia, monon antigen and anti-monon antibody assay for candidiasis, latex agglutination and enzyme immunoassay for cryptococcus, the point-of-care or test lateral flow assay for aspergillus and cryptococcus, also the detection of cryptococcal antigen in cerebrospinal fluid, serum or urine provides a definitive diagnosis of cryptococcal infection. This approach often offers more rapid results to aid with diagnostic decision-making. Antigen detection can be used to screen high-risk patients to invasive fungal infections, facilitate early diagnosis, and also to monitor the response to therapy. The clinical performance of these tests tends to vary widely based on the etiologic agent, specimen type, host characteristics, and the testing algorithm used. Radiological evidence from X-rays and high-resolution computed tomography is useful for the diagnosis of fungal infections, and magnetic resonance imaging of the lungs may be performed to avoid radiation exposure. Pulmonary fungal infections such as aspergillosis, fusariosis, cetosporiosis, or zygomycosis are characterized by central cavitation of pulmonary lesions, infiltration, pulmonary nodules, and halo or air crescent signs. Disseminated candidemia may show focal lesions in the liver, spleen, and other abdominal organs. Computed tomography has superior sensitivity in detecting focal hepatosplenic lesions which appear hypodense. While sinonasal invasive fungal infection on imaging appears as soft tissue opacification of the sinonasal cavity with mucoperiosteal thickening, with variable degrees of bony erosion. Skull-base osteomyelitis and contiguous central nervous system spread of infection can occur as a complication. Central nervous system infections and invasive fungal infections vary depending on the organism. Central nervous system aspergillosis may be seen on imaging as multiple areas of embolic infarct secondary to meningitis and involvement of perforating vessels, multiple ring-enhancing lesions, or contiguous involvement of the dura associated with adjacent sinusitis or skull-base osteomyelitis. Screening patients with probable and proven invasive pulmonary aspergillosis by magnetic resonance imaging of the brain is recommended even in absence of neurologic signs or symptoms. Central nervous system mucormycosis is usually associated with sinusitis and bone erosion. Disseminated hematogenous candida infection may result in meningoencephalitis. The imaging findings include meningeal enhancement and multiple ring enhancing or nodular lesions in the brain parenchyma. Globally, molecular techniques can help to make a diagnosis of invasive fungal infection via the detection of fungal DNA or RNA in suitable samples. Molecular techniques are rapid, less invasive, and provide reliable species identification. They can be applied directly to clinical specimens. Molecular techniques that are helpful in invasive fungal infection diagnosis include fluorescent in situ hybridization, microarray, real-time PCR, multiplex PCR, semi-nested and nested PCR, or PCR enzyme-linked immunosorbent assay. However, most PCR-based assays have focused on the detection of invasive candidiasis and aspergillosis till now. Additionally, next-generation sequencing allows for the simultaneous detection and identification of multiple fungal pathogens from a single sample, making it a useful tool for diagnosing invasive fungal infections. Antifungal susceptibility testing is a tool of increasing importance in clinical microbiology laboratories. Therefore, the goal of antifungal susceptibility testing is to reliably produce minimum inhibitory concentration values that may be used to guide patient therapy, inform epidemiological studies, and track rates of antifungal drug resistance. Moreover, several methods have been standardized by international guidelines such as the agar-based methods, including disc diffusion, broth dilution, and the e-test. Other commonly used methods include gradient diffusion and the use of rapid automated instruments such as the Vitex system. Point-of-care diagnostic devices for invasive fungal infection are tests that can be administered quickly and easily at the site of patient care, rather than requiring samples to be sent to a laboratory for analysis. It's worth mentioning that the use of these techniques should be complemented by a comprehensive medical examination of the patient. Some examples of point-of-care diagnostic devices for invasive fungal infections include the Fungi-Tel assay for candidiasis, the Fungi-Quick test for aspergillosis, and the galactomannan antigen test for aspergillosis and pneumocystis pneumonia. These tests can provide results within minutes, allowing for prompt initiation of treatment. The diagnosis of invasive fungal infections is complex and challenging. Traditional diagnostic methods such as direct microscopy, histopathology, and culture are the gold standard techniques. However, they are time-consuming and insensitive. While the newly emerging techniques such as antigenic detection, molecular techniques, and imaging potentially have more clinical benefits. Antifungal susceptibility testing is a tool of increasing clinical importance for tracking fungal drug resistance and guiding therapy and epidemiological studies. Point-of-care diagnostic devices and invasive fungal infections are tests that can be administered quickly at the site of patient care and provide results within minutes, thus hastening treatment decisions.